Good morning, Dr. Dolce, Dr. Wagner, and NYU DNP colleagues. My name is Minzo. I'm the transplant coordinator and nurse practitioner from a large urban transplant center. My quality improvement project I would like to present it to you today is about implementation of high-risk alcoholism relapse scale in a liver transplant outpatient clinic. Our transplant center perform liver and a kidney transplant. Our patients mostly are adult. They're divided by pre and the post liver and kidney transplant. Our transplant professions includes 5 transplant surgeons and 9 nurse practitioners. We have 3 transplant social workers, 1 nutritionist, 1 pharmacist, and a anesthesiologist, and IT staff, research staff, clerical staff. Transplant process comprises 6 phases. The initial consultation, when transplant team meet with patient and their family members. Evaluation period include transplant workup and test report review. Waiting period, once patient meet their candidacy and their name were on the transplant list. Transplant surgery and post-transplant recovery and education, post-transplant care and management are the rest of phases in transplant process. Transplant pattern include weekly physician meeting, monthly staff meeting, service patterns such as consultation, clinic, listing meeting, research, clinical trial, and lab review. No formal risk assessment for alcohol relapse after patient their name were put on a transplant list. There are many merits that matter to transplant service, such as length of stay, hand hygiene, organ survival rate, and patient survival rate. And there is no official data collection for alcohol relapse, but anecdotal evidence has shown relapse had occurred after transplantation. After we diagnose the clinical microsystem, we know the theme for improvement is alcohol relapse risk assessment. Our goal is to improve process of alcohol relapse risk assessment in our outpatient clinic. The process should begin in the initial consultation and end with the alcohol relapse identification and referral for relapse counseling. By working with this process, we expect improve nurse practitioners' knowledge of alcohol relapse risk assessment, improve multidisciplinary teams' consensus in determining candidates' eligibility for transplantation listing, improve patients' compliance after organ transplant, and reduce relapse. It's important to work on this right now because we have identified numerous alcohol relapse in post-transplantation. Through literature search, 6 articles are obtained to support this project. 2 were systematic review with meta-analysis, and 2 prospective cohort studies, and 2 retrospective cohort studies. All the study has large sample size, and they were conducted in multiple centers. Validity and reliability of tools were discussed, and results were statistically analyzed. Risk factors effect was quantified. Study had limitation, but overall quality of evidence is moderate to high. In summary, this study has shown us relapse is predictable and preventable. Contributive factors exist, and collecting relapse data is important for clinical practice. Alcohol risk assessment has many clinical implications. It can assist practitioners to capture early relapse. The standard relapse assessment tool can diminish the disparity in determining candidacy transplant eligibility. Data obtained may help to explain the relevant factor that associate with relapse. This is transplant workup flowchart. It starts with when patient come into the office and ends with post-transplant care. In the initial transplant consultation, we have informal alcohol relapse risk assessment. Once the risk is identified and patients referred for transplant listing, if there is no risk identified, patient will go through the standardized transplant workup until their name was put on the transplant list. The high-risk patient normally were recommended to attend alcohol relapse prevention program, and they need to be abstinent for at least 6 months. Once they meet their criteria for listing, and their name will be put on the list. And here is under transplant and post-transplant care. Our specific aim is to implement a standardized alcohol relapse assessment method by using the high-risk alcoholism relapse scale with 100% success of compliance throughout the pre- and post-transplant continued care within 6 months. Using the fishbone diagram to analyze why alcohol relapse risk assessment is lacking, we realize transplant patients normally underreport their alcohol use. They refuse to attend relapse prevention program. Moreover, other confounding comorbidity of liver disease such as hepatitis B, hepatitis C, and hemochromatosis make alcohol liver disease as a primary diagnosis more difficult to make. Transplant provider lacks a relapse assessment training. They do not want to involve with some ethical issue, and they do not want to increase their workload. Transplant social workers are the only one provide alcohol screening in the department, and they are the only one monitor relapse and patient's compliance. The environment in the transplant department is very fast-paced, and we need extra room to conduct interviews. And we normally don't randomly send patients for alcohol blood and urine test. The IT is not favored to implement alcohol relapse assessment. There is no documentation template installed in IT system. The electronic medical record are incomplete. The provider normally do not receive warning if the test report were positive. Transplant have purchased breathalyzers intended to detect or capture alcohol drinking. However, this machine is still sitting in social worker's office and never been used. So the treatment plan is to measure for improvement. We want to achieve 2 goals. Number 1 is to document the percentage of patients identified at high risk of relapse. It will be calculated as following formula. The denominator will be number of patients were assessed. The numerator is the number of patients were identified at high risk. That gives us a percentage. Number 2 goal is to document the percentage of nurse practitioners' compliance in utilizing the standardized risk assessment tool, such as the HRAR tool. So the denominator is the number of HRAR tool were placed in patient's chart. The numerator is the number of HRAR tool were used in risk assessment. So the transplant team will use repeated rapid tests of change based on the stringing together PDSA cycles to attain the aim regarding improving the alcohol risk assessment process. That will conclude my presentation. Thank you for listening.